anesthesiologists are always going to want to over-order in order to make sure that they have on hand what they need to keep the patient alive. Intraoperatively, liver transplant passes through 3 phases. The first phase is the pre-anhepatic phase. The pre-anhepatic phase starts with induction of general anesthesia, placement of vascular access by the anesthesiologist, central lines, arterial lines, additional IVs, as well as, of course, endotracheal intubation and other monitors. Through incision, dissection out of the structures of the liver, including the hepatic arteries, the portal vein, the bile duct, and the vena cava. Once the liver is mobilized and all of these structures have been identified and controlled, they are sequentially ligated or clamped, and we proceed into the anhepatic phase. During the anhepatic phase, the patient is without a liver. So those vessels are clamped, the liver is no longer receiving blood and isn't functional anymore, and then it is removed from the body. And then the new donor organ is immediately prepared, it is taken off of ice, and they begin sewing the donor organ into the patient. Usually that proceeds with anastomosing the vena cava from the donor organ to the recipient, then the portal vein, and then we proceed to the neohepatic phase. The neohepatic phase begins the first time warm oxygenated blood passes into the donor liver. And that usually happens after the completion of the portal vein anastomosis. The portal vein is then unclamped, and blood flows in through the portal vein and is flushed through the liver until blood begins to come out the vena cava on the other side. Typically, up to a liter of blood is flushed into the liver, and usually the surgeons wait until 300 ml or so come out the other side. That is considered a complete blood flush. Then the cava is closed off and blood is allowed to continue to flow in through the portal vein and out through the vena cava. That is usually the most hemodynamically unstable part of the case. When during reperfusion, there is sudden rapid effective blood loss out of the patient and into the new liver and then out into a suction canister. And then also as the new liver is joined with the systemic circulation, there is diffuse recirculation of potassium, other inflammatory factors, and sometimes storage solution as well. Then, after successful reperfusion, the arterial anastomosis is completed, the bile duct anastomosis is completed, and once the patient appears to have hemostasis, they are closed up and either extubated or taken to the ICU, depending on what condition they're in. So those are the 3 phases of the liver transplant. The pre-anhepatic phase, which is largely concerned with dissection, the anhepatic phase, which is concerned with sewing in the new liver, and the neohepatic phase, which is the reperfusion of the liver and the completion of the additional anastomoses. Anticipated blood transfusion requirements in liver transplant are a mix of factors: surgeon preferences and surgeon capability, and the illness of the patient. The optimal algorithm for identifying high-risk patients who are going to require large blood transfusions does not exist. There are some data to suggest that higher MELD score patients will require more blood. Patients with higher sequential organ failure assessment scores will require more blood. And those patients who have reduced maximum amplitude, either on their TEG or equivalent maximum clot firmness on ROTEM, are also patients who are going to bleed more significantly. So patients who meet some of those criteria, we can anticipate that they will need more blood products, and so often more blood products are ordered in advance. Some patients bleed more than others, usually due to either anatomical factors that put them at risk of injury and bleeding, or because their existing liver is so dysfunctional that they bleed more during the pre-anhepatic phase, or if the new liver does not function well immediately and it takes time for them to start to generate their own coagulation factors, and they remain coagulopathic for a long period of time after reperfusion. Bleeding is generally, in the pre-anhepatic phase, bleeding is usually due to anatomical issues, large varices, portal hypertension, unanticipated problems with dissection. Those tend to be large volume, rapid bleeds, and are only concerned and are best controlled through surgical intervention, clamping, suturing, cautery. In those situations, as anesthesiologists, we are primarily concerned with transfusing in order to keep up with blood loss. Post-reperfusion, in the neohepatic phase, blood loss is most commonly due either to unanticipated errors with anastomoses, which are generally not common and easily fixed, or due to profound systemic coagulopathy in the case of a liver that is not working well immediately. In that case, our transfusion strategy as anesthesiologists is primarily concerned with reestablishing normal coagulation and coagulocompetence. Even in centers with a lot of experience, with experienced surgeons and experienced anesthesiologists, it can be very difficult to predict which patients are going to require large volumes of blood. And accidents and misadventures sometimes happen in the operating room. Most transfusions take place after reperfusion of the new liver during the neohepatic phase. Usually the requirement is for blood components that promote coagulation, cryoprecipitate, platelets, and to a lesser extent, red blood cells and fresh frozen plasma or other plasma products. Large volume bleeding is much more likely to occur in the pre-anhepatic phase during cases where there is surgical misadventure, or unanticipated issues with the dissection. In those cases, we are much more likely to be giving red blood cells and FFP or other plasma products in an effort simply to keep up with the volume loss from bleeding and not hemodilute the patient any more than is necessary. During the anhepatic phase, it is rare to need to transfuse briskly during the anhepatic phase, although it does occasionally happen. Anhepatic phase bleeding is most likely the result of an uncontrolled bleed somewhere in the portal system that, while the portal vein is clamped, is under much higher pressure than it would normally encounter. In those cases, usually the best solution is to proceed as rapidly with the sewing in of the new liver as possible and attempt to keep up with the bleeding until such time as the portal venous clamp can be removed, the pressure on the bleed slows down, and then it can be quickly and easily repaired. When Lotzer products are being given, we are either attempting to keep pace with bleeding in order to make sure that the patient gets blood so they can deliver oxygen to their tissues, or we are trying to restore coagulocompetence by giving them factors that will help them produce clot. Sometimes we're doing both things at once. Usually, though, when we are trying to keep pace with bleeding, it is because the holes in the patient's vasculature through which they're bleeding are big holes, holes that aren't going to simply be plugged with enough clotting factors. In that time, we are simply trying to keep pace with bleeding until the surgeons can stop the bleeding. When we're giving things like cryoprecipitate and plasma, and when we're trying to restore coagulocompetence, that is usually because we are trying to stop microvascular bleeding, things that it's difficult for the surgeons to stop and are best stopped with the patient with clotting factors, platelets, fibrinogen, plasma, and other clotting factors. The thoughtful anesthesiologist is trying to both deal with the problem that is currently happening with the patient and anticipate how they are going to not just keep up with bleeding, but how are they going to put themselves into a good position when bleeding is over. If you give, for example, huge amounts of red blood cells and FFP and put the patient into a state of volume overload when suddenly the bleeding is stopped, you then put yourself in a position where you may want to give cryoprecipitate and platelets, but the patient has become volume overloaded, and you now are in a position where it may be desirable from a coagulation standpoint to give something, but it also may harm the patient to give those same things. So it involves a balancing act on the part of the anesthesiologist in order to both keep pace with bleeding, but also look for that time when it is going to stop and make sure you're landing in the place where you want to be landing. Oftentimes, you don't know when the surgeons are going to regain control because they are busy. They're working on putting in sutures, putting on clamps and clips, making sure that they have control of things. And usually you find out that the bleeding is controlled when the bleeding is controlled. In that case, you may be calling the blood bank and ordering in anticipation of ongoing bleeding, and then suddenly discovering that you've over-ordered. Anesthesiologists are always going to want to over-order in order to make sure that they have on hand what they need to keep the patient alive.